Welcome to Physiology. This is Chapter 1. So Chapter 1 is basically an overview of many of the concepts that are fundamental to physiology and future chapters. So first and foremost, we do need to discuss what is physiology and why do we care? Physiology is the science of how the body works. Anatomy is the study of the structures, whereas physiology is the how. How do these structures do the things that they do? How do they work together to do the things the body does? This makes physiology extraordinarily beautiful. Extraordinarily complex, but extraordinarily beautiful. And by studying physiology, you will broaden your overall scientific outlook because in order to understand physiology, you have to dig. Physiology is lots and lots and lots of complex concepts that we try and simplify as much as possible. We simplify them for teaching purposes, but we also simplify them for understanding purposes because your doctor is not going to get into the thing about the nitty gritty of how this what reacts with this and this and this and this and this and this. Yeah, they had that class, like you are, but it's an overall simplified concept is what they're actually going to use. But in order to get that simplified concept, you have to understand and have a knowledge of the deep, complex background components. The other thing with this physiology class, and we're going to see it as we're talking about this system and that system, body functions are highly integrated. No system can survive on its own. They are all interdependent on each other in some way, shape, or form. And most importantly, this is a work in progress. If you've ever asked your doctor a question and they're like, we don't know. Could be, they don't know, but it could also be the scientific community as a whole does not know. Okay. So it's a work in progress. The more we learn that we don't know. Okay, we discovered this. Why? How? Why, if we poke this, does this over here jiggle? So to speak. So this is a constant work in progress. All right. Continuing our overview here, you do need to be aware of organs and organ versus organ systems. Organ systems, remember, are a collection of organs that perform a particular task. So this is going to be your muscular system, your skeletal system, your reproductive system, your digestive system, nervous system. Organs are the structures within those systems that are composed of at least two different tissue types that perform specific functions within this system. Organs can belong to more than one system. Case in point, your kidneys. The kidneys belong to both the urinary system and the endocrine system. Your ovaries, your testes, those are both endocrine and reproductive system. So organs can belong to more than one system. And just a reminder of the systems, there are 11 of them. You have your endocrine, your nervous, your muscular, and your skeletal. Now here it has muscular skeletal. They are two different systems. We do tend to talk about them in conjunction with each other because they are integrally tied together, but they are two different systems. Cardiovascular, respiratory, urinary, gastrointestinal, otherwise known as digestive, reproductive, immune, and integumentary. Integumentary is your skin. Here's the thing, we're not going to talk about all of these systems. We just simply do not have the time. Now, the systems that we are unfortunately going to skip over are these bottom ones, and skeletal, to be perfectly honest. So skeletal, GI, repro, immune, and integumentary, we are not going to talk about. We might touch on some components of them as they tie into other systems, but we're not going to spend any time with them. Immune by itself can be an entire semester. of the why, the physiology. If you're lucky enough to have access to it for either your program or the college you're going to, I do not believe even in our nursing program we offer it, but if you go to like UCO or anything like that, OU, you may have the ability to take a immunology class. That is an entire semester on the how and the why of the physiology of the immune system and the immune response. Bear in mind, it's an entire semester, but it still only scratches the surface. Same thing with reproductive, GI. They're very, very heavily integrated and complex. Now we do need to talk about external versus internal. External environment is going to be anything that is on the external side of the epithelial body barrier, aka the skin. So this is going to be, obviously everything outside of you. But this also includes the air in your lungs. That is considered external environment until that air diffuses across the lung membrane. It is considered external. The food in your stomach is also considered external, as is the urine in your bladder. However, once that food leaves the stomach, it is considered internal. Internal is the immediate environment of most cells, so this is going to include your tissue fluid and your plasma. Tissue fluid is typically actually referred to as interstitial fluid. It's the fluid around all other cells. And plasma is going to be the fluid that is around your blood cells. So plasma is the liquid component of your blood. Chair is squeaking. These external and internal environments are going to be constantly exchanging with each other. External is going to go to plasma will go to tissue fluid, and tissue fluid will go to cells, and then reverse that direction. What's going to come in? So what's going to go external to plasma and then plasma down the chain? That's going to be things like your nutrients and your oxygens. What's going to go plasma to external, so outwards, is going to be your waste and other unnecessary, unneeded products. So where do these exchanges happen between the external and the internal, specifically external and blood? That's going to be at your lungs. We'll talk about that in detail, and that's going to occur in our final module. This will also occur in the gastrointestinal tract, specifically, most commonly, the small intestines. Unfortunately, we are not going to discuss that. And then the kidneys is our other exchange site, and that is going to be discussed also in Module 4. How do these exchanges occur? Well, it depends on where we are. In the GI tract, this is going to be through absorption and secretion mechanisms. In the kidneys, this is going to be filtration, reabsorption, secretion. And in the lungs, it's going to be diffusion. Now, external versus internal. The internal, as we mentioned, there are multiple different facets, and these facets are going to be divided into compartments. Now, these compartments are going to contain specific sets of fluids. These compartments are separated by epithelial membranes. These membranes are going to be semi-permeable, so they're only going to allow select fluids to cross. Fluids, when we talk about fluids, we have to talk about total body water, or TBW. This is all of the water, all of the liquid component that is found within your body. This is water and anything that is dissolved within it. This includes not only the plasma surrounding your blood, so the liquid component of your blood, but it also includes the liquid found within your cells and the liquid surrounding every single cell in your body. Doesn't matter if it's skin, GI, bone, there is fluid surrounding it. So this total body water is going to be subdivided. Typically, a body fluid and its corresponding compartment are going to have the same name. So first compartment is going to be intracellular fluid, or ICF. Second compartment is going to be extracellular fluid, or ECF. ICF is going to refer to the fluid that is found within your cells. We do have another name for this, that is cytoplasm. Extracellular fluid is going to be any fluid that is found outside of a cell. Doesn't matter where, it is simply outside of the cell. So for ECF, this is going to be further subdivided into two main categories. These categories are going to be plasma and interstitial fluid. Plasma is going to refer to the fluid surrounding our blood cells. Interstitial fluid is going to refer to the fluids surrounding all other cells. And it will look something like this. If you have a total body water of about 42 liters, your ICF would be 28 of that 42, so over 50% is found within your cells. The ECF would be that remaining 14 liters. Of that 14 liters, 3 of that is plasma, and 11 is interstitial. So the vast majority of the fluid in your body is found either in or surrounding most of the cells in your body. For those who like numbers, here's an example for you. So if you have a 70 kilogram male, that's a male who is approximately 144? 140, 150 pound male. He would have a total body water of 42 liters. So about 60% of his body weight would be water. 40% of his body weight would actually be ICF, or intracellular fluid, because 28 liters is intracellular. 14 liters would be that extracellular, so about approximately 20% of his body weight would be in fluid that is found outside of the cell. Of that, the division is about 20% of the ECF is plasma, about 80% is extracellular. All right, we cannot talk about your body without talking about homeostasis. I like to refer to homeostasis as your body's happy place. This is its ideal operating zone. This is the zone in which it wants to operate. And I say zone on purpose. Your body is not set at a set number. Depending upon the feedback mechanism used, it is going to bounce back and forth around a set number. So it is a zone of ideal operation. Disease is going to occur when the zone, the numbers get outside of that zone, and your body is unable to return those numbers to that zone. Okay. Because examples are better for everything. What would be an example of this? We're going to use temperature. Temperature is actually going to be our first lab. And so the ideal zone for temperature is 98.6 degrees is what we say our temp is. However, if I take my temperature, I'm not sick, and I take my temperature from the minute I wake up and every hour after that until I go to bed, what I will find is that very rarely will I get a readout of 98.6. Frequently, it will be somewhere between 98 and 99. Might bounce a little bit below or a little bit high, but it will be in a range around 98.6. Now, if I were to do that every single day, I would see that this is normal. And that is because of negative feedback. Negative feedback, I might be getting ahead of myself. 1 second. Yeah, I'm getting ahead of myself. So we'll talk about negative feedback in a moment. Okay, so backing up just a second, what is controlled by homeostasis? Everything. Temperature, volume, the composition of fluids, everything is controlled by homeostasis. Everything. Homeostasis does require the integration of all of your organ systems, most notably your cardiovascular and nervous systems, and your endocrine system. But everything has to be integrated. As I mentioned, when this homeostatic mechanism is interrupted, this is when you have disease. And eventually, death. So with homeostasis, there are some terms that we need to be aware of. What are these terms? First and foremost, regulated variable. What is a regulated variable? It is the thing that we are trying to maintain the status quo of. Body temp, blood sugar levels, blood sodium levels, blood calcium levels, thyroid hormone levels. Whatever it is that we are trying to maintain a set amount of, that is the regulated variable. Okay, here's where I've started to get ahead of myself. Negative feedback. What is it? Basically, it looks like a wave. Think of a sine wave from math class. Draw a top line and a bottom line, and then draw a dotted line in the middle. That dotted line is the number that we want to maintain. So if our number starts to drop below, it will continue to drop until it hits that bottom solid line. When that bottom solid line, the number goes below it, the system will trigger one of several mechanisms, depending on what we're talking about here. That's our variable. And it will cause that variable to go back up. And so it'll go back up past through the bottom line, through the dotted line. It will keep going up until it goes above the top solid line. When it goes above the top solid line, whatever mechanism was turned on to bring it back up will get turned off, and a mechanism will be turned on to bring it back down. And so then it will drop back below that top solid line, past the dotted middle line, below the solid bottom, and you switch off whatever is making it drop and turn back on whatever needs to be turned on to make it go back up. It looks like a wave. And it will yo-yo back and forth between a high top and a low bottom number, with the average being that dotted number. And this is self-correcting. It happens automatically. You don't need to think about it. It's happening right now as you're listening to this, everywhere in your body, with everything. And that is negative feedback. Negative feedback is the most common feedback mechanism in our body. The other feedback mechanism is positive feedback. And I'll get to that one in a moment. So some other terms is set point. A set point is the expected value. So when we say, oh, your temperature should be 98.6, that is the set point. Blood sugar, we say it should be 100 milligrams per deciliter. That is the expected value. But if you look at lab work, it is a range. It's usually 80 to, I haven't looked at lab work recently, it's either 100 or 120. When we do blood pressure, it is a range, but we're looking for, 110 over 80, right? Smack dab in the middle. But we'll like anything between 100 and 120 over 80. Blood pH, 7.4 is what we'll tell you. But when we actually get to the lab where we talk about pH, we're going to tell you it's 7.35 to 7.45 is the range that it can be at. Real quick, fun fact about body temperature. So I lost my train of thought for a second. So there have been some studies that have been ongoing, and they've looked at various generations. And what they did with these generations, starting with the silent generation, is they have looked at their average body temperature. Now, do you know where the 98.6 degrees Fahrenheit as our body temperature comes from? Probably not. That number was determined back in the late 1800s, like 1860, 1880, somewhere in there. So it is over 140 years old. It is a very outdated number. We've never really done much with it since. So these researchers went and they looked at this information, and they looked at each generation, silent generation, boomers, Gen X, millennials, what's the next one? Gen Z. And I don't think they looked at Gen Alpha. And they looked at their average body temperature. And what they found is that the silent generation was 98.6. Boomers were still a little right around there, but they were starting to be below 98.6. And then every generation since has had a lower body temperature average. So Gen Z, their average body temperature is actually about 97.5. So if a Gen Z has a temperature of 98.6, that's more likely to be a fever. Now, here's the thing with this research. It's just showing a trend that our core body temperature is trending down. It does not and did not get into why. That was not the scope of the research. And they even said it in the research paper. They were like, we should probably do some more research to try and figure out why. And so I do believe there is some research going on about that, but we won't probably hear anything from it for 5 to 10 years. So yes, core temperature, we're told 98.6, but depending on the generation, it's actually probably lower than that. Now, from a medical standpoint, did that research change anything? No. Your doctor is still going to use 98.6. Which brings up another fantastic point. Most of the time, if research is going to make a change on how we treat patients, it typically takes 20 years after the research is published for there to be any implementation of it in the healthcare setting. Yes, most of the best practices that our healthcare providers are using are 20 plus years old. And I will just leave you with that thought as we move on. All right, what is the error signal? The error signal is simply the difference between what the expected value is and what we actually got. Did we do much with error signal information? Not really. What are some of the regulators for homeostasis? Well, we are going to need a receptor, an integrating center, an effector, and a signal. So a receptor is what's going to be receiving the information, telling the body that, hey, this is the number for blood sugar, blood calcium, blood pressure, whatever the case is. That information is going to be sent to an integrating center, which is then going to go, hey, this is too high, this is too low, this is great. And depending upon the information, it will then send out a signal to an effector, and this effector is going to then cause our variable to go up or down. It's going to trigger, the effector is going to make a change happen. And the signal is just going to be the information that is being sent back and forth. Receptors, there are a variety of them. They are simply parts of your system that detect stimuli. You're going to have thermoreceptors. These are going to be more heat-related. Chemoreceptors, these are going to be more chemical-related, since variations in chemical. And then baroreceptors, and baroreceptors are going to deal with pressure differences. As I mentioned, integrating centers are going to orchestrate the appropriate response based on the information received. Most of these integrating centers are going to be found in the brain, and we will mention some of them as we go along. Effectors are going to be the body's response to the signal. So muscles would be an effector, regardless if they're smooth striated or cardiac. Various glands, the blood vessel walls, signals are what allow for communication. Input signals are going to go from the receptor to the integrating center, and output are going to go from the integrating center to the effector. These can be either chemical or electrical, and we will talk about both chemical and electrical messages. This is an example of a negative feedback loop. Here we have our change in our variable, it's increasing. Here we have our set point. That information is going to go to the integrating center, which in this case is actually going to be the beta cells of the pancreas. This is going to trigger an increase in the signals to the effectors. These effectors are going to be the cells throughout the body, and this is going to trigger a response, which is a decrease in blood glucose. Now, what is this signal? If you know anything about blood sugar regulation, then you know increase in blood sugar means a release of insulin. Now, this is the other one, the one that I started to talk about and then said I was getting ahead of myself. This is a positive feedback loop. Positive feedback loops feed on themselves. So an example of a positive feedback loop is actually going to be oxytocin. Now, this one uses LH secretion. LH is secreted by the pituitary gland, which affects the ovaries to increase estrogen secretion. That increase in estrogen secretion is going to trigger the release of more LH, which will trigger the release of more estrogen. The example that we like to use is oxytocin. Oxytocin is also released by the pituitary gland, and it's specifically released during labor contractions. So we have our initial trigger, that first contraction, and that triggers the release of more oxytocin. Oxytocin is going to cause more and stronger contractions. The more contractions, the stronger contractions are going to trigger the release of more oxytocin, which is going to trigger the release of more contractions and stronger contractions. And it's just going to feed into itself until we get a stop signal. So where a negative feedback is a wave, positive feedback is a circle with an arrow showing it feeds into itself. All right, this back half is simply talking about some clinical connections, specifically looking at heat exhaustion and heat stroke, regulation of temperature. Heat exhaustion is going to lead to massive amounts of sweating. You are overly warm, and your body is still going to try and maintain its normal temperature. It is still going to be operating in negative feedback. It's still going to try and bring you back to 98.6 degrees internally. So in order to do that, it's going to trigger all of its heat-releasing systems. So massive sweating. Sweating is a major component of reducing your temperature, which is why it doesn't work well when you have a high humidity. So massive amounts of sweating. We're going to reduce blood volume because blood contains heat. But also, well, the other thing is massive sweating, you're losing water. We're going to reduce blood volume because we're going to be becoming dehydrated. We are going to increase blood flow to the skin. Increasing blood flow to the skin is going to allow us to vent and release more heat. This is, as I mentioned, still going to be operating in negative feedback, but because of these mechanisms, push of blood to the skin surface, dehydration due to massive sweating, which in turn is going to reduce blood volume. This is going to reduce your overall blood pressure. The reduction in blood pressure is going to cause you to feel dizzy and possibly cause you to faint. Because of that rush of blood to the surface of the skin and the massive amount of sweating, you're going to be flushed and you're going to be wet. You're sweating like crazy. Versus heat stroke. Heat stroke is actually going to be operating in positive feedback. We have moved through heat exhaustion. We have worked through all of our available mechanisms, and our body has now started to function abnormally. And so instead of actually trying to reduce the temperature, we're actually going to be elevating it. We're still going to have blood flow to the surface of the skin, but we're not going to have sweating going on. We're still going to have reduced blood volume, though. We're still going to have reduced blood pressure because of that blood flow and reduced blood volume. Because of that increase in temperature, though, we are going to have delirium. We're going to be flushed, but we're going to be dry. Of the two, heat stroke is a medical emergency. We are going to the ER. We are not trying to treat this on our own at home. We need to reset our feedback mechanism. Once we've kicked ourselves back over to negative feedback, the way it should be operating, we can treat this at home. But once we're in this is a medical emergency. We're also going to, here at the back half, talk about the diabetic epidemic. We pick on diabetes a lot. Why do we pick on diabetes a lot? Because it's extraordinarily common, and while it has a relatively simple mechanism of work, blood sugar is elevated, and we are unable to reduce that blood sugar due to a variety of different reasons. The effects of that increased blood sugar is felt throughout the entire body. So diabetes mellitus, the term diabetes is actually Greek, meaning to siphon, while mellitus is actually Latin, meaning honey or sweet. So it's a combo mixed language word meaning to siphon honey, referring to that elevated blood sugar. So blood glucose levels are elevated. When blood glucose levels are elevated, we're going to see an increase in glucose in urine. Why exactly, we'll talk about actually with the urinary system. And this abnormal increase in glucose is going to actually affect our blood plasma levels. Why is it going to affect our blood plasma levels? Due to diffusion properties, diffusion and osmosis properties. So we'll talk about those later in a different chapter. Some signs and symptoms of diabetes: excessive thirst, so polydipsia, as well as massive fluid loss, polyuria, and then polyphagia, excessive hunger. As we mentioned, it affects every organ system. These numbers are outdated. This information is probably more from like 2007, 2013. So these are very outdated numbers, but they haven't necessarily gotten better. So when this data was collected, this was the prevalence of diabetes on age and sex across the United States. So when you think of diabetic patient, what age bracket do you tend to think of? 65 and older. And that's not necessarily incorrect. About 11.2 million people at this time, which is about 25% of the people with diabetes. However, the next bracket, 20 to 64, is almost as much. It's 20%. Now it is theoretically a larger population because you have 44-ish years versus probably 20 years, 20 to 30 with our 65 up. But it's still a huge percentage. And then younger than 20 is about 0.25%. Now here's the thing. What this doesn't divide up between is the two different types of diabetes. There are two different types. There's type 1 and type 2. Type 1 is a genetic defect, might be a good word for it. It's basically your body is not creating insulin. It's completely stopped. And we tend to know for most individuals if they have type 1 diabetes by the age of 8. So this 200,000 number of people with diabetes is probably type 1, but we don't know that for a fact. Between the ages of 20 and 65 up, that is probably type 2. Type 2 is more of a lifestyle disease. Basically, your body becomes, over time, unable to handle. It's a wear and tear. This could be due to genetics. It could be due to lifestyle. There's a lot of different variables with type 2, but is usually a later in life condition, which is a great time to point out. If you have family members who have type 2 diabetes, you may want to make sure you are keeping an eye on your own blood sugar, because it does tend to have a genetic component. Now, if you were to think of gender, male versus females, they're pretty even. Women are about 11.2 and men are about 13.6. If I were to ask you what ethnicity, well, you probably would immediately thought white, unless you have any other background with diabetes. But they're only 7.6. Unfortunately, our Native Americans, in their group, they are about 15.9% likely to have diabetes. Those of African descent, 13.2. Those of Hispanic descent, 12.8. Our Asian descents are 9. So, but here's the thing, and it does mention this down here. This is based on prevalence of a specific group. And this shows that 5.5% of Alaskan natives are likely to have diabetes, whereas our Southwest natives are more likely to have it at a prevalence of 33.5. So this is an average. Your different Native American groups will have variables. Same thing with our Africans and our Hispanics and our Asians. This is also going to have a variation on the number. So I don't know if this is the actual number. Let's say we have 50 million whites. We might have a large number of them that have diabetes, but because their overall population size is so high, the number with diabetes are going to end up being a smaller percentage. Whereas if I only have a population of 1,000 Native Americans, even if only one person has diabetes, it's going to have a bigger impact. So this gets into stats. If you like stats, if you like these probabilities and all of that, then you can have a field day with this. And this data is from 2014, by the way. So this one we do actually have a number with. This little table is showing you the prevalence of diabetes in the world over time. So this is the number of cases recorded in the millions, starting in 1985 and all the way to, well, let's say this is our actual information here, 2013, and this over here is predicted based on the trends that we're seeing. If we don't identify these trends and break these trends, this is the predicted trajectory. As you can see, lots of people. All right. One of the things that we use when we're, talking about health in general is this thing called BMI, body mass index. It measures your weight relative to your height. So this is going to be in the metric system, kilograms divided by height squared. And this is how we use to define obesity. And I have lots of things to say about this. So first of all, the current markers are, if you are overweight, that means your BMI is 25 to 29. If you're obese, it's 30 to 39. Morbid obesity is anything over 40. And typically that's going to be about 100 pounds of being overweight. Here's the thing. These are just numbers. This does not actually look at your body. You can have somebody who is 5'2" and weighs 160 pounds. You have two people side by side. They're both 5'2", they're both 160 pounds. One of them you would look at and say, yep, they're overweight. They've got some extra fluff. You can see it. The other person is ripped. They are jacked. But according to the BMI, they are also overweight. It does not look at body composition at all. So you could be a weightlifter or bodybuilder. You could be ripped. You do the what's it called? Competitive bikini competitions and all that fun stuff. The competitive showing off where you do all that posing and stuff. You could be ripped, not an ounce of body fat on your body. Based on the numbers, you're overweight. So why do I point this out? Because you have to look at your patient. You can't just look at a BMI. There's a couple other things with this. The BMI, they actually changed it about, what year is it? 15 years ago. They actually changed the BMI indicators, the numbers, and shifted it down. So people who before were fine, according to the old BMI, were suddenly overweight. Why did they do that? It was completely arbitrary. There was no scientific data to back up the shift. Which brings me to the most important part. 2 summers ago now, The AMA, no, it was last summer, the AMA, American Medical Association, voted, and it passed, that a BMI can no longer be used for obesity indicators, because it was never meant to be. Many doctors would take your BMI and that's it. They would not look at you. They would not do a fat calibration, nothing. They would take your BMI and go, oh, you're overweight. You're morbidly obese. You need to lose weight. They would not look at you. They would not look at your actual body composition. So, the fact that you're ripped. They would not look at your fat body percentage. They would not look at anything beyond the BMI. And so now, according to the AMA, and it is slowly being rolled out, remember this is a trickle effect, they are starting to, and part of this is getting insurance companies and all that fun stuff on board. It can no longer be the only factor in your diagnosis of a patient being overweight. You have to actually look at your patient. So it seems like a really small thing, but it's really, really, really important, because a lot of doctors were just using the BMI. They were not looking at their patient, which is horrible to say. So, sorry, I will get off my soapbox. Okay, why did we talk about BMI here with diabetes? Because they linked the likelihood of you developing type 2 diabetes with your BMI. So that's why one of the recommendations when you have a patient who has, their first diagnosed with type 2 diabetes, one of the first recommendations out of a doctor's mouth is lose weight. And for some patients, that works. However, you can be skinny mini. You can have a BMI of less than 25 in the normal range, and you can still have type 2 diabetes. Weight and BMI are not the only factor. We mentioned genetics. It's a huge thing. So while they use this and there is a seeming correlation, it is not the only factor. That's what we talk about here. So types of diabetes, as we mentioned, type 1 versus type 2. Type 1, you do not make insulin. Type 2, you make insulin, but you have an impaired response to it. Now, type 2 diabetics can eventually stop making insulin, but usually that is chronic, especially if they are not managing their diabetes. Somebody is considered pre-diabetic if they have blood glucose levels between 100 and 125 milligrams per deciliter over the course of multiple testings. This is not a one and done. Approximately, based on this data, which, as I mentioned, is old, 79 million Americans were deemed pre-diabetic based on their blood sugar numbers. The reason this matters is because if you are pre-diabetic, this is the easiest time to get it under control. It's far easier to get it under control in the pre-diabetic stage. But the other reason is if you're pre-diabetic, you are likely to develop type 2 diabetes within 10 years. So it's a precursor. We also, though, have to talk about gestational diabetes. This is considered a subclass of type 2. Obviously, you will be pregnant if you have gestational diabetes. This is why if you become pregnant, they have you do a bunch of blood work, and then you have to chug this. I'm told it's like flat orange soda, although it does apparently come in different flavors now. It's a very sugary liquid that you chug down. And then they routinely, over the course of the next 3 hours, check your blood sugar, and that's a glucose tolerance test. They're testing your response to taking a bunch of sugar, and it is an indicator for how likely you are to develop gestational diabetes, as well as doing regular blood sugar testing. Why do we care? This has massive implications and complications with your pregnancy, but if you have gestational diabetes, studies suggest that you are more likely to develop type 2 diabetes post-pregnancy. Why do I say they suggest? There's so many different factors involved, but the research indicates that there's a causation, there's a correlation here. And then there's diabetes insipidus. Diabetes insipidus has the name diabetes in it, but is completely unrelated to diabetes mellitus. It's actually a completely different organ involved, and this is going to involve urination, and specifically is going to affect the antidiuretic hormone known as vasopressin, that system. So it has nothing to do with blood sugar. How do we diagnose diabetes? Well, depends on how we're testing. If we are doing a fasting plasma glucose test, this is the gold standard. We want it to be between 60 and 100. If you're pre-diabetic, it will be 100 to 125, and anything over 125 is considered diabetic. Now, we can also do an oral glucose tolerance test. That's that drinking the sugary fluid I mentioned. Basically, what we're looking for is for your blood sugar to peak at 139 or less after taking the blood or the drinking the fluid after doing a fast. Pre-diabetic would be if it peaks between 140 and 199, and anything over 200 would be considered diabetes. Now, back in the 80s, 90s, we discovered a lovely little test that made doctors extraordinarily happy when they were treating diabetic patients. Because up until this time, they would have their diabetic patients, they'd say, hey, I need you to do this, this, and this, take this medication, blah, blah, blah. And the patient would go home, say, yep, go home and not do it at all. And then, 2-3 weeks before their next appointment, they'd actually start doing what they were supposed to do. And they would come in, they'd get the blood work tested, and the doctor, it'd be normal, it'd be good, but they'd have signs and symptoms of unmanaged diabetes. So diabetic neuropathy, retinopathy, ulcers, gangrene, they'd have these uncontrolled diabetic symptoms, and the doctor would be going, I don't understand. Your blood sugar's fine. You say you're doing what you're supposed to be doing. What gives? And then we discovered hemoglobin A1C. And basically what hemoglobin A1C is, it looks at the blood glucose that is tagged to blood cells over the course of 2 to 3 months. So these patients who are only doing what they're supposed to be doing, like 2 to 3 weeks before their appointments, now got called out because it would show that they actually weren't doing it, because this is showing long-term control. What are some symptoms of diabetes mellitus? Well, dehydration, fatigue, lethargy, coma, changes in your eye and kidney microvasculature. This is why if you have diabetes, you should be going to the eye doctor so they can check the blood vessels in your eyes, because diabetes can cause you to go blind due to that. Issues with your heart, issues with your stomach, neuropathy, erectile dysfunction, atherosclerosis. Pick a symptom, pick a system. It will affect it. Treatment? Well, anything to get it less than 120. If we can keep and maintain your blood glucose under 120, 100 is ideal, but we'll do 120. This minimizes the occurrence of eye disease, kidney disease, and nerve damage, and incomplete healing of skin wounds. How do we do this? Diet. Diet is a huge factor. What's not included on here with diet is exercise. For whatever reason, exercise seems to trigger a mechanism, especially in pre-diabetics and early diabetic stages, of triggering a mechanism that allows the cells that aren't responding to insulin to actually respond to insulin the way that they're supposed to. And it's not just during exercise, it does continue on for several hours post-exercise. So exercises also should be on here. Insulin can be given to diabetic patients, but that is typically only given in chronic end-stage diabetic patients, because you're still making insulin, at least in the beginning. We don't give insulin until, usually, the body is no longer making its own or not enough. I say usually because this is going to vary depending upon the patient. But insulin is not our first drug of choice. Instead, we're going to prescribe things like sulfonylureas and megalotinids, These are going to stimulate the secretion of insulin. We can also prescribe thiazolidinediones. Welcome to pharmacology, where it's its own thing. These particular medications are going to enhance the effect of insulin, making it more effective, as well as decreasing liver glucose production. Your liver makes glucose. So if you have high blood sugar, we don't want your liver creating more glucose. And that is the end of chapter 1. See you in chapter 2.